presentation. I have nothing to disclose. Conventional endoscopy and therapeutic endoscopy of the entire small bowel has previously not been possible without surgical assistance. EGD can only assess the assess a very proximal jejunum, while push enteroscopy only examines the first 100 centimeters of jejunum. Colonoscopy can only reach the distal ileum, and capsule endoscopy allows visualization of the entire GI tract but does not allow for therapeutic options. Laparoscopic assisted push enteroscopy is both invasive and challenging. Adhesiolysis or laparotomy may be necessary if previous surgery, and adhesiolysis can increase the risk of small bowel injury. Intraoperative endoscopy can have a morbidity rate up to 30% and a mortality rate of 2%. Double balloon enteroscopy presents a new paradigm for diagnosis and treatment of small bowel diseases. This procedure was originally described by Yamamoto et al. In 2001. They were able to endoscopically examine the entire small bowel in one patient. Double balloon enteroscopy uses a balloon tip enteroscope loaded in an overtube, which also has a distal balloon. The inflated double balloons grip the intestinal mucosa and allow for further advancement of the endoscope. Here you can see the double balloon enteroscope, and on the left is the overtube loaded over the scope, and on the right you can see both the balloon at the tip of the scope and at the tip of the overtube. The technique of DBE works by inflating the balloon at the tip of the enteroscope. The overtube is advanced over the enteroscope while its balloon is deflated. Then the overtube's balloon is inflated while the scope's balloon is deflated, and withdrawal of the overtube results in pleating of the intestine onto the overtube. When these maneuvers are repeated serially, they allow for pan-enteroscopy. Indications for DBE include occult GI bleed, intestinal masses, strictures, foreign body diagnostic, and examination of the stomach, duodenum, and biliary tree in surgically bypassed patients. Therapeutic interventions include snare polypectomy, mucosal biopsy, injection therapy, tattooing, balloon dilation, argon plasma coagulation, ERCP, and PEG tube. Severe complications have been reported, which include bleeding, intestinal perforation, pancreatitis, and enteritis. 3 out of 39 patients at our institution have had intestinal perforations from DBE. The first case was a 23-year-old female with a history of ulcerative colitis who had a 2-stage laparoscopic proctocolectomy and ileoanal pouch. She had a 6-year history of abdominal pain, and a DBE was performed to evaluate the etiology of the pain. Her peranal scope was passed to 250 centimeters, and 2 biopsies were performed. She developed a fever and left pleural effusion on post-procedure day 4. A CAT scan was obtained which revealed a perforated viscus. She underwent diagnostic laparoscopy and had repair of 2 small bowel enterotomies. Postoperatively, she developed intra-abdominal abscesses that needed to be drained percutaneously and was later discharged home with eventual removal of the drains. Our second case was a 59-year-old female with positive fecal occult blood on 2 occasions. She also had a previous surgical history with a hysterectomy for uterine bleeding and eventual hernia repair and paniculectomy. She had a negative EGD and colonoscopy, and capsule endoscopy revealed arteriovenous malformations in the mid and distal jejunum with bleeding. A poor oral DBE was performed without visualization, so we were consulted for a laparoscopic assisted lysis of adhesions, and a DBE was performed at that time. Both AVMs were able to be endoscopically sclerosed. However, she had persistent pain and ileus that were initially attributed to endoscopic insufflation. A CAT scan was obtained and revealed also perforated viscus. She required a laparotomy and repair of 2 intestinal enterotomies. She had a lot of swelling and required an open abdomen, which was subsequently closed 1 week later. Our third case is a 28-year-old female diagnosed with FAP on screening colonoscopy. She also had a significant surgical history with ileorectal anastomosis and subsequent small bowel resection for a bowel obstruction. A poor oral DBE was performed to 250 centimeters, and she developed immediate post-procedure pain with signs of pneumoperitoneum on plain films and also required an exploration. She had a small perforation right by her small bowel anastomosis. DBE certainly is an advanced endoscopic procedure. Repeated withdrawals and advancements must be correctly correlated to the inflation and deflation of 2 different endoscopic balloons. DBE requires experienced endoscopists and a nurse to manipulate the overtube and control the balloons. The learning curve to achieve proficiency is probably unknown. Forward advancement of the overtube is performed without visualization. One should not apply excess when passing the tube. Intra-abdominal intestinal adhesion may increase the likelihood of the mucosa becoming wedged between the scope and the overtube, and this could result in perforation. All 3 cases of perforation had previous surgery with resultant adhesion at our institution. Yamamoto et al. Had a total of 2 perforations out of 178 procedures. Heaney et al. Reported a 1% rate of pancreatitis. In addition, 20% of their patients had abdominal pain, which resolved within 24 hours. Mensink et al. Conducted a retrospective study examining the complications of DBE in 10 different centers across 4 different continents. The overall complication rate for DBE, for their diagnostic DBE, was 0.8%, which is similar to complication rates during diagnostic colonoscopy. However, during therapeutic DBE, 3 perforations were a result of argon plasma coagulation, and 2 perforations happened during balloon dilation. They also had 18 cases of bleeding during therapeutic DBE. Their complication rate for therapeutic DBE was 4.3%, which is twice as high as complication rates for therapeutic colonoscopy. Madezidade performed 237 DBEs among 6 tertiary centers in the United States. Their only perforation was perforation of a fresh ileostomy for refractive GI bleeding that needed a double balloon enteroscopy. May et al. Reported a complication rate of 3.4% during therapeutic DBE. There were 2 episodes of bleeding, 3 perforations, and 1 episode of enteritis. And Wu et al. Had no complications during 258 DBEs. The severe complication rate varies from 0 to 3.4% in the current medical literature. 3 intestinal perforations occurred from DBE at our institution for a complication rate of 7.7%. I think a relative contraindication to double balloon enteroscopy may be previous surgery, and double balloon enteroscopy should only be performed by experienced endoscopists.
Thank you very much.
Thank you.
I have a quick question. Were any of the perforations potentially due to the therapeutic options you chose? For example, you sclerosed 2 lesions. Were you able to tell at surgery that those were not involved with the perforation sites? Because your implication is that the perforations are due to tears from the progression of the scope.
Yeah. It's hard to say whether during the sclerosing that they were affected, but we know that none of the perforations were a result of, in the second case, for example, the lysis of adhesions, because when double balloon enteroscopy was performed, there wasn't any perforations visualized at that time.
Well, I would say it's possible. I mean, it's possible you have a delayed, during lysis of adhesions, you can have an unnoticed, even with air in the gut, you could have an unnoticed or a very thin area that later thinned out and perforated. But I do think your warning and your data is very important, because the small bowel is sort of the last unreachable territory. And as you point out, although capsule endoscopy is excellent and is improving all the time, it's not and doesn't hold much hope for being a therapeutic modality.
Yes, I have a question. The first case, how do you know the perforation was not due to instrumentation during laparoscopy? It was a laparoscopy-assisted procedure.
Because the laparoscopic stuff was performed before the DBE, so during DBE, none of the perforations were visualized, so we're thinking that it was happened because of the double balloon enteroscopy.
A minimal, manipulation of the bowel.
Yeah, minimal manipulation of the bowel also. We use atraumatic bowel graspers.
One other quick question, since no one's standing at the mic. What amount of time would you say on average does it take to do one of these studies? As you're doing them, do you perceive it to be a risky procedure? Can you tell when you're having trouble? In other words, could a prudent endoscopist do this and back off and probably not develop these complications, or are these complications occurring in a